Hello everyone, you're watching sqadia.com. Suppose a patient comes to you with a swollen first metatarsal joint and there is an acute history and patient is complaining of pain and patient is in agony. What do you suspect? Gout, right? So if it is gout, how would you manage it? In this section, we'll be going through the history, examination, and differential diagnosis of gout. What else we should be thinking about when we're dealing with patients of acute gout, treatment of acute and chronic gout, and are there any surgical options in gouty arthritis? So, whenever we talk about a management of a case, we start from the detailed history. What else you should be thinking about, as we have differentiated on the history whether it was a primary gout, there is something wrong with the metabolism, or it is the secondary gout, there is something wrong with the kidney's excretion. Our patient is not able to excrete the amount of uric acid which is actually being produced. On history, we have to take detailed history of acute episodes, how many, how far apart, and what have happened over, when was there any treatment taken, was there any labs was done previously. Association with diet, especially purine-rich diet. Patients, especially in certain parts of the world, they tend to take a lot of liver, especially in certain occasions, and the kidney and liver and these organs of the body are actually they contain a very lot of purines. So if the patient is taking high amount of liver in the body diet, this may be the reason that there is acute nucleotide breakdown leading to increased amount of uric acid formation and resulting in an acute flare-up of the gout. Is there any history of previous episodes? Is there any family history? His parents or his siblings, any one of them is actually suffering from gout, because there is some degree of genetic predisposition as well. Are there any associated cardiovascular abnormalities, diabetes, or anything? Because in case of hypertension or cardiac diseases, usually the kidney is affected in the long term, and kidney excretion is actually decreased. If kidney excretion is less, there is quite likely that the patient may be having a secondary gout, because uric acid production is normal in body, but the excretion is not there. So there is relative hyperuricemia in our body. Coming to then, after detailed history, then comes examination. Now, examination could be local and general. Local is whatever the joint. If the patient comes with the knee swelling, you have to examine the knee, the other knee as well, for the comparison. And then there is a generalized examination as well. We have to rule out other causes which may be involved or not with the gout as well. Then assessment of other joints with swelling. If there are any other nodules present in the body, they all should be examined properly. There may be other joints which may have been swelling, there may be nodularity, but they may be painless, and patient may be complaining of only pain in one of the joints, but that means that it's something which is a global problem. So the patient is all multi or polyarthropathy is positive in this case. Now, if a patient comes to you with, let's suppose, this knee which is shown in the diagram, if you see over here, the patient comes to you and says, okay doc, I have this problem, I have a pain from last 3 to 4 days, there is swelling and I'm unable to bear weight, and this is quite a lot painful when I move my knee, and how would you differentiate? Now if you see just this picture, there is definitely, you can appreciate swelling over here. There is erythema or orangish peel which is quite very apparent. Now you have to differentiate, is this a pus, or this is infective knee, or this is gouty arthritis? Now, but just looking at it, you probably won't be able to judge it, but careful history, detailed examination of this knee and the other knee and other joints of the body probably tell you, okay, most likely if there is no history of fever, patient labs of, let's suppose, CRP, ESR and blood CP is within normal range, and its uric acids are high, so most likely this is going towards a gouty arthritis or acute flare-up of the gout rather than infection of the knee. So what else we should be thinking of when we are dealing with acute gout? It includes septic arthritis, which would be on the top priority, or first thing in our mind. Then calcium pyrophosphate arthritis, acute inflammatory arthritis. These are some of the important differentials which we should be considering along with the gout. Now, why I'm talking about calcium pyrophosphate is that it's not necessarily urate. It could be any other crystal deposition disorder, which may mimic some kind of a pseudo gout or podagra kind of thing. So we have to be sure that this is not infection, this is not calcium deposition, this is simply uric acid deposition leading to gout. Once, how would actually, this is a table which shows that what happens in gout and what happens in septic arthritis. It could be, usually it's monoarticular, sometimes only knees swelling, sometimes only first metatarsal joint is involved, but gout usually have an increased predilection for the first metatarsal joint, while septic arthritis somehow presents more in the knee rather than the small joints of the body. Coming to the, sometimes they both can be polyarticular. There could be a fever, but if you see it's 3+ with septic arthritis. With septic arthritis, there's definitive history of fever. At times, patients presents late and there is key swelling and then they develop superadded infection. That's why it looks like initially septic, but then it later on it comes out to be gout. Now, coming to the resolution of symptoms, usually it takes 7 to 14 days. And in case of septic arthritis, it will get worse until unless you treat it. Coming to the risk factors, renal insufficiency, obesity, hypertension, and medications. While immunocompromised host, if patient is on steroids, or intravenous drug abuser, or patient has a prosthetic joint, or even AIDS, they are usually most prone to infection like in septic arthritis. Elevated CR, sometimes CRP, ESR could be raised in both. But that is where the clinical judgment actually comes in. But in case of septic arthritis, there's acute onset of symptoms, there is a marked increase of TLC. While there could be almost normal TLC or slightly raised TLC in terms of gout. If you see synovial fluid analysis of the knee joint, then it will be 2,000 to 100,000, but they're usually typically 50,000 and above. And coming to the synovial fluid microscopy, they would now, that is why sometimes it's very difficult to differentiate septic and gout. But the most important, most specific test for ruling out gout along from septic arthritis is actually synovial fluid microscopy in the birefringent light. And polarized light, it actually shows negative birefringence or needle-shaped urate crystals. While in case of septic arthritis, that will be negative, but if you do gram staining or ZN staining, that would eventually come out positive. Serum uric acid is always high in gout, and usually it's nothing to do with septic arthritis. So if you're suspecting gout, it's uric acid and synovial fluid microscopy, which would show negative birefringence in polarized light. Once you have made the diagnosis, how do we treat gout? Most common is if a patient has acute onset of symptoms, there would be an agony, and that is you need to control the pain. Analgesics or anti-inflammatory agents are the first line of choice. For example, it could be indomethacin, it could be naproxen, it could be etoracoxib, celecoxib. Usually etoracoxib are actually avoiding renal impairment, CCF, and peptic ulcer disease, but they can be given nowadays. We have enteric-coated NSAIDs which can be easily given in case of peptic ulcer disease as well. Then it's steroid. In acute attack, yes, there is a role of steroids. Intraarticular only if the joint is affected. Orally or intramuscular if the joint access is difficult or gout is polyarticular. For example, if a patient comes to you with first metatarsal and knee gout, knee swelling, yes, we can get an intraarticular injection. But if a patient comes to you for example, this gout, there's a back pain, and actually the spine is affected, so you cannot injection back into the spine. So the other option is either give orally or give it intramuscularly, so that some degree of steroids goes up there to that point. So what other drugs we can use for macrotherapy includes colchicine. that should be initiated early in 0.5 milligram 4 times per day, tapering over a week. GI side effects includes diarrhea and nausea, and for some it could be cumbersome. But this is actually mainly it's divided. Acute gout treatment is divided into two things. One is targeted pharmacotherapy, and the other is supportive treatment. Now, but I was just discussing this NSAID and the steroids. These are kind of a supportive as well. You give rest to the limb, you give analgesia and supportive measures so that the misery and agony of the patient decreases. Then coming to the pharmacotherapy, the targeted therapy is use of colchicine. Other includes rest, ice packs, splinting with the powerful analgesia. Now, splinting will actually decrease the movement of the joint, so there will be decreased pain. Similarly, ice packing would actually decrease the swelling and inflammation which is occurring at the joint. Coming to the treatment of chronic gout, if the patient has multiple flare-ups, the patient is a chronic gout patient, then their first thing should be the patient education. That patient has to be told that there are certain diets, especially which contain high degree of purines. You cannot take too much meat, you cannot take too much liver and kidney, you cannot take red meat and you cannot have red wine because they're going to increase your uric acid levels. Appropriate lifestyle modification, weight loss, dietary advice such as reduction of alcohol and fructose and abundant. Now, there are problems at times. What happens is in certain parts of the world, for example, in Middle East, there is people tend to have used a lot of honey. Now, honey actually contains fructose, and this also increases amount of uric acid production in our body. So that has to be the patient has to be counseled properly that you need to change your diet so that there's decreased amount of uric acid production in the body. Then there is urate-lowering therapy, which is targeted how to decrease the amount of uric acid in our body. And then there are certain xanthine oxidase inhibitors, which is called elaboration, and now febuxostat has come into play as well. This is a new drug of choice, but they are all xanthine oxidase inhibitors. The starting dose of elaboration is 100 milligram per day, but 50 milligram, even 50 milligram on alternate days should be considered elderly or those with the renal impairment. That's important. Now, this is the purine metabolism. If you see it over here, the conversion hypoxanthine to xanthine is actually inhibited by xanthine oxidase inhibitors. That's why, because once xanthine hypoxanthine gets converted to xanthine, then it becomes uric acid. Then there's urate-lowering therapy, which once the uric acid, there are two ways to deal with it. You stop forming of increased amount of uric acid, but all that uric acid which has been already formed, there has to be a mechanism to reduce that, and that is actually to enhance the excretion which has already been formed. Allopurinol is the drug of choice, which is a xanthine oxidase inhibitor. Starting dose is 100 milligram, but you can go as high as 300 milligram per day as well. Other new alternatives include febuxostat, which is also xanthine oxidase inhibitor, but there is a difference. It is metabolized and excreted by liver, not by kidneys. Now, if the patient was having a secondary gout and patient is hypertensive and there's a lot of renal impairment, then the problem with allopurinol is that you cannot give allopurinol in high doses in these patients. And if patient is having a lot of symptoms, then you're getting kind of a stuck, because although allopurinol will lower the uric acid level, but its excretion in its high doses will not take place and get accumulated. Once it gets accumulated, then it can also have toxic effects in itself. So in case of kidney diseases, and which is actually quite common, and there were a lot of patients who had gout due to kidney diseases or secondary to kidney diseases. So in that, if the liver is working properly, yes, you have another organ which can metabolize the drug, and that can work. The uric acid production can be easily taken down, and there will be no increased accumulation of the drug because now the liver can metabolize the other drug. Coming to the uric drugs, which actually decrease the amount of uric acid in the blood by increasing its excretion. These include probenecid and sulfenpyrazone, which act by inhibiting urate-1, which is urate transporter 1. Now this is, as you can appreciate, there is an proximal tubules of the kidney on the apical border, and the uric acid is actually absorbed back into the basolateral membrane. But once this is blocked, then this uric acid cannot be absorbed back, and there is increased excretion in the body. Thank you very much. Keep watching sqadia.com.